What are the core components of informed consent, and in what situations may a physician proceed without obtaining full informed consent from a patient? Answer: informed consent requires that the patient understands the nature of the proposed treatment, the risks involved, the potential benefits, and available alternatives, and also mandates that the patient comprehends the consequences of refusing treatment. The physician must ensure the patient's competence and voluntary participation. Exceptions to obtaining full informed consent include emergency situations when immediate medical intervention is necessary to prevent death or severe harm and the patient is unable to provide consent. Therapeutic privilege in rare cases, when providing full disclosure may cause severe psychological harm to the patient, physicians may withhold certain information. Incompetence. For patients who are deemed legally incompetent, consent must be obtained from a legal guardian or surrogate. Implied consent. This applies to non-invasive routine procedures where explicit consent may not be required but is implied by the patient's actions, such as routine blood draws. Relevant laws. Patient Self-Determination Act, PCDA, HIPAA regulations. A 57-year-old male presents to the clinic with complaints of chest pain that started suddenly while climbing stairs. He has a history of hypertension and hyperlipidemia. His vital signs are stable, and EKG shows nonspecific ST changes. How would you differentiate between an acute coronary syndrome ACS and stable angina in this patient? Answer: in differentiating ACS from stable angina, the critical factor is the nature of the chest pain. Acute coronary syndrome ACS typically presents with pain that is new, occurs at rest, or has increased in severity or frequency. Stable angina, on the other hand, is chest pain that occurs with exertion and is relieved by rest or nitroglycerin. ACS symptoms are often associated with other signs like diaphoresis, nausea, and a sense of impending doom. Diagnostic tests include cardiac biomarkers, troponins, which are elevated in myocardial injury as seen in ACS, but not in stable angina. Relevant guidelines. The American College of Cardiology (AC) recommends immediate evaluation with EKG and cardiac biomarkers for chest pain suggestive of ACS. Additionally, the American Heart Association (AHA) highlights the need for immediate intervention in the form of antiplatelet agents, anticoagulation, and possible percutaneous coronary intervention (ECI) for confirmed ACS cases. A 65-year-old female patient with hypertension is prescribed a new antihypertensive medication that acts by blocking the action of angiotensin I at the receptor level. Explain the mechanism of action of this drug class and discuss the physiological effects that occur as a result of this blockade. Additionally, provide the implications of this mechanism on renal function and electrolyte balance. Answer: the drug in question belongs to the class of angiotensin I receptor blockers, ARBs. These medications, such as losartan or valsartan, inhibit the binding of angiotensin I to its type 1 receptor. Angiotensin I is a potent vasoconstrictor and plays a critical role in regulating blood pressure by promoting sodium retention, increasing aldosterone secretion from the adrenal glands, and stimulating thirst. Physiological effects. Vasodilation. Inhibition of angiotensin I leads to decreased vascular resistance, resulting in low blood pressure, reduced aldosterone secretion. This results in decreased sodium and water reabsorption in the kidneys, promoting diuresis and further lowering blood pressure. Improved renal perfusion. The drug can help maintain renal blood flow by preventing excessive constriction of the efferent arterioles. Implications on renal function and electrolyte balance. Patients may experience hyperkalemia due to decreased aldosterone levels, which normally promotes potassium excretion. Renal function should be monitored as ARBS can cause acute renal failure in patients with renal artery stenosis due to their effect on glomerular filtration pressure. Discuss the concept of ischemia and its effects on cellular metabolism. Include in your discussion the biochemical pathways that are disrupted during ischemia and the potential outcomes of prolonged ischemic events in tissue. Answer: ischemia is defined as the reduced blood flow to a tissue leading to insufficient oxygen and nutrient supply, which is critical for cellular metabolism. This condition primarily disrupts aerobic respiration, pushing cells toward anaerobic metabolism. Biochemical pathways affected: reduced ATP production. Oxygen deprivation halts oxidative phosphorylation in the mitochondria, significantly decreasing ATP production. This results in a failure of HAP-dependent processes, including ion pumps, G-natriapase, lactic acidosis. As glycolysis increases to compensate for ATP loss, lactic acid accumulates due to the conversion of pyruvate in the absence of oxygen. This leads to a decrease in pH, further impairing cellular function. Increased free radicals. Reperfusion injury can occur upon restoration of blood flow, leading to oxidative stress from the sudden influx of oxygen, damaging cell membranes, proteins, and DNA. Potential outcomes of prolonged ischemia. Cellular injury progresses from reversible injury, cellular swelling, fatty change, to reversible injury, leading to necrosis or apoptosis. In organs like the heart, prolonged ischemia can result in myocardial infarction, while in the brain it can lead to stroke. Compare and contrast the roles of innate and adaptive immunity in response to a viral infection. Provide specific examples of cellular components and molecular mediators involved in each immune response. Answer: innate immunity is the first line of defense against pathogens and is characterized by its immediate but non-specific response. Key components include phagocytic cells. Macrophages and neutrophils engulf and destroy pathogens. Natural killer NK cells recognize and destroy infected or cancerous cells through the release of perforins and granzymes. Cytokines, such as interferons, ifins, inhibit viral replication and promote an antiviral state in neighboring cells. Adaptive immunity is specific and slower to respond, developing a targeted response to pathogens. Key components include T lymphocytes. CD T helper cells activate other immune cells, while CD autotoxic T cells directly kill infected cells. B lymphocytes produce antibodies that specifically target viral antigens, leading to neutralization and opsonization of pathogens. Memory cells ensure a faster, more robust response upon re-exposure to the same virus. Define the term tumor microenvironment and explain how it contributes to tumor progression and metastases. Include specific cellular and molecular interactions that occur within this microenvironment. Answer: the tumor microenvironment (TME) refers to the surrounding cell's extracellular matrix, ECM signaling molecules, and blood vessels that interact with tumor cells. It plays a crucial role in tumor progression and metastases through the following mechanisms: cellular interactions, tumor-associated fibroblasts, TAFs, and immune cells, e.g. tumor-associated macrophages can promote tumor growth by secreting growth factors, e.g. TGF-beta that stimulate proliferation and angiogenesis. Extracellular matrix remodeling. The CM undergoes changes, becoming more permissive for tumor cell invasion. Proteases like matrix metalloproteinases, the MMPs, degrade CM components, allowing tumor cells to migrate. Hypoxia. Tumors often develop areas of low oxygen hypoxia, leading to the activation of hypoxia-inducible factors, HIFs, which promote angiogenesis and metabolic adaptations in tumor cells. Immune evasion. The TME can inhibit the function of immune cells, allowing tumor cells to evade immune surveillance. For example, program death ligand 1 PDL on tumor cells combined to PD-1 on T cells, leading to T cell exhaustion. A medical student is studying the brachial plexus and its clinical significance. Explain the anatomy of the brachial plexus, including its roots, trunks, divisions, cords, and terminal branches. Additionally, discuss a common injury that can occur in its clinical manifestations. Answer: the brachial plexus is formed by the ventral rami of spinal nerves (CT) and can be divided into several segments. Roots (CT), which emerge from the spinal column and pass between the anterior and middle scalene muscles. Trunks: the roots unite to form three trunks: upper CC, middle C, and lower CT. Divisions: each trunk divides into anterior and posterior divisions. There are a total of 6 divisions. Cords: the divisions reorganize to form 3 cords, lateral, posterior, and medial, named based on their position relative to the axillary artery. Terminal branches: from the cords arise major nerves, including the musculocutaneous, median, ulnar, radial, and axillary nerves. Common injury: a classic example is the Werb's palsy, which results from excessive traction on the neck during delivery. This injury typically affects the upper trunk, leading to weakness in shoulder abduction and external rotation, as well as elbow flexion. E.g. affected muscles include deltoid, supraspinatus, and biceps brachii. Explain the concept of pleiotropy and provide an example of a genetic disorder that demonstrates this phenomenon. Discuss the underlying genetic mechanisms and how they contribute to the very phenotypic expressions seen in such disorders. Answer: pleiotropy refers to the phenomenon where a single gene influences multiple phenotypic traits. This occurs when a gene product affects various biological pathways or processes. An example of a pleiotropic disorder is Marfan syndrome, caused by mutations in the FBN gene, which encodes fibrillin-1. Phenotypic expressions: skeletal abnormalities. Individuals often exhibit tall stature, long limbs, and arachnodactyly due to effects on connective tissue. Cardiovascular issues, aortic dilation or dissection can occur due to weakened connective tissue in the cardiovascular system, significantly increasing morbidity and mortality. Ocular problems. Patients may experience lens dislocation due to alterations in the structural integrity of the eye's connective tissues. Underlying mechanisms. The mutations in FBN disrupt the assembly of elastic fibers, affecting various tissues, leading to diverse clinical manifestations. The interplay of genetic, environmental, and developmental factors influences the severity and variety of symptoms. Discuss the histological characteristics of chronic inflammation and how it differs from acute inflammation. Include specific cell types involved and the significance of the extracellular matrix in chronic inflammatory conditions. Answer: chronic inflammation is characterized by a prolonged inflammatory response, often lasting for months or years, and involves a different cellular composition compared to acute inflammation. Key characteristics include cell types. Lymphocytes. Predominantly T cells and B cells accumulate, contributing to the adaptive immune response. Macrophages. Activated macrophages play a pivotal role in phagocytosis and secretion of pro-inflammatory cytokines. Plasma cells secrete antibodies specific to antigens present in the tissue. Tissue changes. Unlike the neutrophil-dominated response seen in acute inflammation, chronic inflammation often results in the formation of granulomas, which are organized aggregates of macrophages surrounded by lymphocytes. Extracellular matrix (ECM). In chronic inflammation, the CM undergoes significant remodeling with increased deposition of collagen and other components. This can lead to fibrosis and scarring, impairing normal tissue function. Differences from acute inflammation. Acute inflammation is characterized by rapid onset, short duration, and a predominant neutrophilic response, whereas chronic inflammation is slower, sustained, and involves lymphocytes and macrophages with tissue repair mechanisms. Describe the mechanisms of antibiotic resistance in bacteria. Discuss the implications of antibiotic resistance on public health. Answer: antibiotic resistance in bacteria arises through various mechanisms, significantly complicating treatment options. Key mechanisms include enzymatic degradation. Bacteria can produce enzymes such as beta-lactamases, which hydrolyze beta-lactam antibiotics, rendering them ineffective. Alter target sites. Mutations in the target sites, e.g. penicillin-binding proteins, can prevent antibiotics from binding effectively. Efflux pumps. Some bacteria have developed efflux pumps that actively expel antibiotics from the cell, reducing their intracellular concentration. This is commonly seen in multidrug-resistant strains of Pseudomonas aeruginosa. Reduced permeability. Changes in the bacterial cell wall can decrease the permeability of antibiotics, preventing their entry. Gram-negative bacteria often exhibit this mechanism, leading to resistance against aminoglycosides. Public health implications. The rise of antibiotic-resistant infections poses a significant challenge, leading to increased morbidity and mortality, longer hospital stays, and higher healthcare costs. The need for new antibiotics and the implementation of antibiotic stewardship programs are critical to combat this issue. A 70-year-old male patient presents with a history of smoking and persistent cough. A lung biopsy reveals the presence of atypical squamous cells. Discuss the potential pathways of carcinogenesis in lung cancer, emphasizing the role of environmental factors. Answer: lung cancer, particularly squamous cell carcinoma, is strongly associated with environmental factors, particularly tobacco smoke, which contains numerous carcinogens, e.g. polycyclic aromatic hydrocarbons. The pathways of carcinogenesis can be broken down into several key stages. Initiation. Carcinogenic compounds induce genetic mutations in epithelial cells of the lung. Common mutations involve oncogenes, e.g. CROS, and tumor suppressor genes, e.g. TP. Promotion. The damaged cells undergo clonal expansion due to continued exposure to carcinogens. In the case of tobacco smoke, the chronic irritation leads to dysplasia of the epithelial cells. Progression. Further genetic alterations accumulate, leading to increased cellular proliferation and loss of normal growth control. The transition from dysplasia to carcinoma in situ occurs as mutations accumulate, ultimately leading to invasive cancer. Environmental factors. Besides smoking, other risk factors include exposure to radon gas, asbestos, and air pollution, all of which can contribute to the carcinogenic process. Explain the mechanisms of action of non-steroidal anti-inflammatory drugs, NSAIDs, and discuss their therapeutic uses as well as potential side effects associated with long-term use. Answer: Non-steroidal anti-inflammatory drugs (NSAIDs) are a class of medications widely used to reduce inflammation, relieve pain, and lower fever. Their primary mechanism of action involves the inhibition of cyclooxygenase (COX) enzymes, which are crucial for the conversion of arachidonic acid to prostaglandins. Prostaglandins play significant roles in mediating inflammation, pain, and fever. Mechanisms of action: COX-1 inhibition. COX-1 is involved in the production of prostaglandins that protect the gastric mucosa, maintain renal blood flow, and regulate platelet aggregation. Inhibiting COX-1 can lead to gastrointestinal side effects and impaired renal function. COX-2 inhibition. COX-2 is induced during inflammation and is responsible for producing prostaglandins that mediate pain and swelling. Selective COX-2 inhibitors, e.g., celecoxib, aim to reduce inflammation while minimizing gastrointestinal side effects associated with COX-1 inhibition. Therapeutic uses: pain management. NSAIDs are effective for mild to moderate pain relief, such as headaches, menstrual cramps, and musculoskeletal pain. Anti-inflammatory, used in conditions like arthritis, tendinitis, and other inflammatory disorders. Antipyretic. NSAIDs can lower fever through their action on the hypothalamus, where they inhibit prostaglandin synthesis. Potential side effects: gastrointestinal. Prolonged use can cause ulcers, gastritis, and gastrointestinal bleeding due to decreased mucosal protection. Renal. NSAIDs can lead to acute kidney injury, especially in individuals with pre-existing kidney conditions or dehydration, as they affect renal blood flow. Cardiovascular. Long-term use of certain NSAIDs, especially non-selective ones, may increase the risk of cardiovascular events, such as heart attack or stroke. Conclusion: while NSAIDs are effective anti-inflammatory agents with multiple therapeutic applications, clinicians must weigh the benefits against the potential for significant side effects, especially in long-term management scenarios. Regular monitoring and patient education on the risks are essential for safe use. Which class of drugs is contraindicated in asthmatic patients for the management of hypertension, and why? Answer: beta blockers, particularly non-selective beta blockers, e.g. propranolol, are contraindicated in asthmatic patients because they can block both B cardiac and B bronchial receptors. The blockade of B receptors in the lungs can lead to bronchoconstriction, precipitating an asthma attack. Selective beta blockers, e.g. atenolol, are less likely to cause bronchospasm, but caution is still advised. Relevant guidelines: according to the Global Initiative for Asthma, GINA, non-selective beta blockers should be avoided in asthmatics, and cardioselective beta blockers should only be used with caution, especially if asthma control is suboptimal. Ms. Thompson, a 65-year-old female, underwent a total hip replacement surgery. On the second postoperative date, she reports shortness of breath, sharp chest pain, and her oxygen saturation is 89%. The EKG shows sinus tachycardia. What is the most likely diagnosis, and what should be your next step in managing her condition? Answer: the most likely diagnosis is pulmonary embolism, a known complication of postoperative recovery, especially following orthopedic surgeries such as hip replacement. The patient's symptoms of dyspnea, chest pain, and hypoxia are concerning for this condition. Management includes immediate initiation of anticoagulation, e.g. low molecular weight heparin or direct oral anticoagulants unless contraindicated. Diagnostic confirmation via CT pulmonary angiography, the gold standard for diagnosing PE. Relevant guidelines: the American College of Chest Physicians Act recommends thromboprophylaxis for patients undergoing major orthopedic surgery to prevent venous thromboembolism. A patient is started on warfarin for atrial fibrillation. What is the target INR range for this patient, and what are the monitoring protocols? Answer: the target INR, international normalized ratio, range for a patient with atrial fibrillation on warfarin is typically between 2.0 and 3.0. Monitoring should begin within 2 to 3 days of initiating therapy, with adjustments made based on the INR results. Once stable, INR should be checked every 4 to 6 weeks. The risk of bleeding increases significantly with an INR 4.0, and the risk of thrombosis increases if the INR is below the therapeutic range. Relevant guidelines: the American College of Cardiology (AC) and American Heart Association (AHA) recommend frequent INR monitoring for dose adjustment and emphasize patient education on avoiding foods high in vitamin K, which can affect warfarin's efficacy. A 72-year-old male with terminal pancreatic cancer is experiencing severe pain. What is the best approach to managing his pain? Answer: managing severe pain in patients with terminal illness such as pancreatic cancer, involves a comprehensive assessment and a multimodal approach to ensure effective symptom control. Pain assessment: evaluate the pain using a pain scale, e.g. 0-1-0 scale, to quantify severity, identify pain characteristics, e.g. nature, location, duration, and aggravating or alleviating factors. Analgesic ladder: according to the World Health Organization (WHO), analgesic ladder pain management begins with Step 1. Non-opioid analgesics, e.g. acetaminophen, NSAIDs for mild pain. Step 2. Weak opioids, e.g. codeine, tramadol for moderate pain. Step 3. Strong opioids, e.g. morphine, oxycodone for severe pain. Given Mr. Thompson's terminal cancer, strong opioids are likely necessary from the outset. Opioid selection: morphine is commonly used due to its efficacy and familiarity. The typical starting dose for severe pain may vary based on prior opioid exposure, but often begins with oral morphine at 1030 mg every 4 hours. Fentanyl patches can be considered for consistent pain control in patients with significant ongoing pain. Breakthrough pain: patients should be prescribed immediate-release opioids for breakthrough pain, often 10-15% of the total daily opioid requirement. Adjuvant therapies: consider medications like antidepressants, e.g. duloxetine, or anticonvulsants, e.g. gabapentin, for neuropathic pain if indicated. Relevant guidelines: the American Academy of Hospice and Palliative Medicine (OPAM) recommends individualized pain management strategies in palliative care, emphasizing the goal of achieving comfort and improving quality of life rather than complete pain eradication. What is the potential interaction between warfarin and antibiotics such as ciprofloxacin, and how should this interaction be managed? Answer: warfarin is an anticoagulant that is metabolized primarily by cytochrome P enzymes, particularly Cyc, CYPA, and CYPA. The antibiotic ciprofloxacin can interact with these metabolic pathways, particularly affecting CYPA and leading to potential increases in warfarin levels. Mechanism of interaction: ciprofloxacin may inhibit CYPA, reducing the metabolism of warfarin, resulting in increased INR and a higher risk of bleeding. Other antibiotics that interact with warfarin can include macrolides, e.g. erythromycin, which inhibit CYPA monitoring. Patients on warfarin who are prescribed ciprofloxacin should have their INR monitored more frequently, typically every 2-3 days after starting the antibiotic and until the INR stabilizes. The target INR should remain between 2.0-3.0 for most indications, with adjustment of warfarin doses made as needed based on INR results. Management strategies: dose adjustment: if the INR increases above the therapeutic range, e.g. 3.5, consider reducing the warfarin dose or holding doses until the INR returns to a safe level. Patient education: advise patients about signs of bleeding, e.g. unusual bruising, bloody urine, or stool, and the need to report these symptoms immediately. Alternative antibiotics: if possible, consider using alternative antibiotics that do not interact with warfarin, such as azithromycin. Relevant guidelines: the American Society of Health System Pharmacists (ASH) provides comprehensive guidelines on managing drug-drug interactions, particularly in patients on chronic anticoagulation therapy. Regular monitoring and patient education are crucial components of safe anticoagulant management. A 45-year-old female presents with symptomatic cholelithiasis confirmed by ultrasound. What is the appropriate timing and indication for surgical referral? Answer: in the case of symptomatic cholelithiasis gallstones, timely surgical referral is crucial to prevent complications. Indications for surgery: symptomatic cholelithiasis: patients who present with recurrent biliary colic, acute cholecystitis, or pancreatitis due to gallstones should be referred for surgical evaluation. The presence of complications, e.g. obstructive jaundice, perforation, necessitates urgent surgical intervention. Timing of surgery: elective surgery, ideally elective laparoscopic cholecystectomy, should be performed within a few weeks of diagnosis to minimize complications. Urgent surgery: if the patient experiences acute cholecystitis indicated by fever, leukocytosis, and right upper quadrant pain, surgery may need to be performed within 24-48 hours to avoid complications such as perforation or necrosis. Surgical technique: laparoscopic cholecystectomy is the preferred method due to its minimally invasive nature, reduced postoperative pain, and quicker recovery compared to open cholecystectomy. Postoperative care: postoperative monitoring for complications, e.g. bile leaks, infections, is essential, along with pain management and gradual return to normal activities. Relevant guidelines: The American College of Surgeons Acts endorses laparoscopic cholecystectomy as the standard of care for symptomatic gallstones, recommending timely intervention to avoid complications and ensure optimal patient outcomes. Which analgesic is contraindicated in patients with a history of gastrointestinal bleeding, and what alternatives should be considered? Answer: nonsteroidal anti-inflammatory drugs, NSAIDs, such as ibuprofen or naproxen, are contraindicated in patients with a history of gastrointestinal bleeding due to their mechanism of action, which inhibits cyclooxygenase (COX) enzymes involved in prostaglandin synthesis. This can lead to decreased mucosal protection in the GI tract and increased risk of ulcers and bleeding. Mechanism of injury: NSAIDs inhibit both COX-1 and COX-2 enzymes. COX-1 is responsible for producing prostaglandins that protect the gastric mucosa. Inhibition leads to increased gastric acid secretion and reduced bicarbonate and mucus production, predisposing to ulceration and bleeding. Alternatives to NSAIDs: acetaminophen, paracetamol, often recommended for mild to moderate pain as it does not affect gastric mucosa. COX-2 inhibitors, e.g. celecoxib. These selectively inhibit COX-2, sparing COX-1, thus potentially offering anti-inflammatory effects with a low risk of GI complications. However, they should still be used with caution in patients with cardiovascular risk factors. Adjunctive analgesics, medications like gabapentin for neuropathic pain or tramadol with caution, can be considered as alternatives. Monitoring and patient education. Patients should be monitored for signs of pain relief and any adverse effects associated with new medications. Education on recognizing GI bleeding symptoms, e.g. black stools, abdominal pain, should be provided. Relevant guidelines. The American College of Gastroenterology Act recommends avoiding NSAIDs in patients with a history of peptic ulcer disease and advises careful selection of analgesics in this population to minimize risks while managing pain effectively. What are the age-related pharmacokinetic changes that affect drug metabolism in elderly patients? Answer: pharmacokinetics encompasses the absorption, distribution, metabolism, and excretion of drugs. In elderly patients, several changes can significantly affect these processes. Absorption. Although the absorption of drugs is often unchanged, there can be delayed gastric emptying and increased gastric pH due to decreased acid production. This may alter the bioavailability of certain medications, especially those requiring an acidic environment for optimal absorption, e.g. ketoconazole. Distribution. Body composition changes. Aging leads to increased body fat and decreased lean body mass and total body water. Lipophilic drugs, e.g. diazepam, may have an increased volume of distribution, leading to prolonged half-lives and potential accumulation. Plasma proteins. Serum albumin levels may decrease, resulting in a higher fraction of free drug for highly protein-bound medications, e.g. warfarin, thus increasing the risk of toxicity. Metabolism. Liver function. Hepatic blood flow and liver size decline with age, potentially reducing the metabolism of drugs. Phase I reactions, oxidative metabolism, are more affected than phase I reactions, conjugation, leading to prolonged effects of drugs metabolized primarily through the liver, e.g. certain benzodiazepines. Excretion, renal function, decreased glomerular filtration rate, GFR, is common in older adults, affecting the elimination of renally excreted drugs, e.g. digoxin aminoglycosides. Creatinine clearance, (CL), should be estimated using the Cockcroft-Gault equation rather than relying solely on serum creatinine, as muscle mass decreases with age, potentially masking renal impairment. Relevant guidelines. The Beers criteria provide recommendations for avoiding potentially inappropriate medications in older adults and highlight the need for dose adjustments based on individual pharmacokinetic profiles to minimize adverse effects and enhance therapeutic efficacy. What are the essential components of informed consent that must be communicated to a patient prior to a surgical procedure? Answer: informed consent is a fundamental ethical and legal requirement before performing any medical intervention, particularly surgery. The essential components include disclosure of information, nature of the procedure, clearly explain the surgical procedure including what it entails, the rationale for performing it, and expected outcomes, risks and benefits. Discuss the potential benefits, risks, and complications associated with the procedure. Risks must be specific, including both common and serious potential complications. Alternatives. Provide information on alternative treatment options, including their benefits and risks, allowing the patient to understand the full scope of their choices. This could include non-surgical interventions or observation. Understanding. Assess the patient's understanding of the information provided. Encourage questions and verify comprehension to ensure the patient can make an informed decision. Voluntariness. Ensure that the patient is giving consent voluntarily without coercion or undue influence. This includes assessing the patient's mental capacity to make informed decisions. Consent documentation. Document the consent process in the patient's medical record. This includes the discussion of risks and benefits, alternatives, and the patient's understanding and agreement to proceed with the surgery. Opportunity to ask questions. Provide an open forum for the patient to ask questions or express concerns. This enhances trust and ensures that the patient feels fully informed before making a decision. Relevant guidelines. The American Medical Association (AMA) emphasizes the importance of clear communication in the informed consent process, stressing that informed consent is not merely a form to be signed, but a process of communication between the patient and physician. A 17-year-old patient presents with a sexually transmitted infection (STI). The patient explicitly requests that their parents are not informed. Under HIPAA and other regulations, what should the physician do? Answer. Under the Health Insurance Portability and Accountability Act (HIPAA) and many state laws, minors have the right to confidential healthcare services, particularly for sensitive issues like STIs, mental health, and reproductive health. Patient autonomy. The 17-year-old has the right to make decisions regarding their healthcare, especially concerning sensitive health issues. Respecting patient confidentiality is crucial for fostering trust in the physician-patient relationship. Legal protections. State laws often allow minors to seek treatment for STIs without parental consent. It is essential for the physician to be familiar with local laws, as these can vary. Many states have specific statutes permitting minors to access reproductive health services confidentially. Informed discussion. The physician should explain the importance of parental involvement in healthcare decisions while respecting the patient's request. The conversation could include discussing the benefits of having parental support while also acknowledging the patient's right to confidentiality. Documentation. It is vital for the physician to document the patient's request and the discussion regarding confidentiality to protect both the patient and the physician legally. Exceptions. If there are concerns about abuse or neglect, or if the patient is at risk of harm to themselves or others, the physician may need to breach confidentiality in accordance with mandatory reporting laws. Relevant guidelines. HIPAA privacy rules, state-specific minor consent laws, American Academy of Pediatrics guidelines on adolescent confidentiality. Mrs. Sanchez, a 75-year-old woman with terminal cancer, has expressed in her advanced directive that she does not want life-sustaining treatment, including mechanical ventilation, should her condition worsen. She is now unconscious and in respiratory distress. Her family is demanding that the medical team intubate her immediately. What should the medical team do in this scenario? Answer. In this scenario, the medical team must prioritize Mrs. Sanchez's autonomy and adhere to her advanced directive, which serves as a legally binding document regarding her healthcare preferences. Respecting autonomy. Mrs. Sanchez's advanced directive clearly states her wishes against life-sustaining treatment. Informed consent principles emphasize the importance of patient autonomy even when the patient is no longer able to communicate their wishes. Ethical principles. The principles of beneficence, acting in the patient's best interests, and non-maleficence, doing no harm, guide the medical team's actions. Providing unwanted life-sustaining treatment contradicts these principles and may lead to additional suffering. Communication with family. The medical team should have a compassionate discussion with the family explaining the implications of Mrs. Sanchez's directive. It may be helpful to involve a palliative care specialist or ethics committee to facilitate the conversation and provide support. Documentation and legal standing. The team should document the advanced directive and the family discussions thoroughly. This documentation can protect the medical team legally should any disputes arise. Alternative care options. The team should consider providing palliative care and comfort measures to ease Mrs. Sanchez's distressing symptoms without violating her wishes. Relevant laws. Patient Self-Determination Act (PCDA). State laws regarding advanced directives. What are the ethical obligations of a physician when treating a patient who is non-compliant with their treatment plan due to cultural or religious beliefs? Answer. Physicians have ethical obligations to respect patients' cultural and religious beliefs while ensuring appropriate care. The following principles guide this process. Cultural competence. Physicians should strive to understand and respect cultural differences. This involves actively listening to the patient's beliefs and values regarding health and treatment. Patient autonomy. Patients have the right to make decisions about their healthcare based on their cultural or religious beliefs. Physicians must honor these decisions provided that the patient is fully informed about the risks and benefits of their choices. Education and communication. Physicians should engage in open dialogues with patients to educate them about their condition and treatment options. Collaboration. If appropriate, the physician can involve cultural liaisons, interpreters, or religious advisors in the conversation to enhance understanding and respect for the patient's perspective. Documentation. Any discussions regarding treatment compliance and the patient's beliefs should be well documented in the medical record to provide a clear account of the patient's decisions and the physician's responses. What are the ethical implications if a physician forms a romantic relationship with a current or former patient, and what actions should the physician take to avoid potential breaches of professional conduct? Answer: the ethical implications of forming a romantic relationship with a current or former patient are significant and can lead to serious consequences. Power imbalance. The physician has a unique power dynamic in the patient-physician relationship. This imbalance can lead to perceived coercion, where a patient may feel pressured to enter a romantic relationship due to the dependency created by their healthcare needs. Ethical guidelines. The American Medical Association (AMA) Code of Ethics prohibits romantic relationships with current patients due to the potential for exploitation and harm. Disclosure and professionalism. If a physician develops romantic feelings, they must disclose this to a supervisory body or ethics committee and cease the professional relationship. Documentation of the termination of care is critical. Referral. The physician should refer the patient to another healthcare provider for ongoing care to ensure that the therapeutic relationship does not influence personal feelings. Continuing education. Physicians should participate in ongoing education regarding boundaries and professionalism to avoid conflicts of interest. Tommy, a 3-year-old boy, has been brought in by his parents, who are concerned that he has not started speaking yet. They note that he seems to understand simple commands but cannot form words. The parents are worried about autism. What developmental milestones should the physician evaluate to assess Tommy's condition, and what further actions are recommended? Answer: in assessing Tommy's development, the physician should evaluate a range of developmental milestones and consider various factors. Developmental milestones. At age 3, children typically should be able to speak in short sentences, 2-4 words, follow simple instructions, e.g., please pick up the toy, engage in parallel play with peers, demonstrate some imaginative play. Assessment tools. The physician should use standardized developmental screening tools, e.g., the ages and stages questionnaires to evaluate Tommy's language skills, social interactions, and play behavior. Hearing evaluation. Conduct a hearing assessment to rule out hearing loss, which could contribute to delayed speech. Observing social interaction. Observe Tommy's interactions with his parents and caregivers to identify social engagement and communication attempts. Signs of autism may include limited eye contact, lack of social smiling, or repetitive behaviors. Referral to specialists. If developmental delays are confirmed, the physician should refer Tommy to a speech-language pathologist for further assessment and potential speech therapy. If autism is suspected, a comprehensive developmental evaluation should be arranged with a pediatric neurologist or psychiatrist. Early intervention. If delays are identified, it is crucial to implement early intervention strategies which can significantly improve outcomes for children with developmental delays. Relevant guidelines. American Academy of Pediatrics Guidelines on Developmental Screening Early Intervention Programs. What are the key considerations in deciding whether to honor a patient's refusal of treatment when their decision appears irrational due to a psychiatric disorder? Answer: when a patient with a psychiatric disorder refuses treatment, several key considerations come into play. Assessment of competence. The physician must evaluate whether the patient is competent to make informed decisions regarding their care. Competence involves the ability to understand the information presented, appreciate the consequences of their decisions, and communicate a choice-informed refusal. If the patient is deemed competent, their refusal must be respected even if the decision appears irrational. Patients have the right to make choices that may not align with medical advice. Risk of harm. If the refusal poses a significant risk of harm, or if the patient is in immediate danger, e.g., suicidal ideation, the physician may need to consider involuntary treatment under emergency psychiatric laws. This usually requires a legal process or consultation with mental health professionals. Substitute decision maker. If the patient is deemed incompetent, the physician may need to involve a substitute decision maker, e.g., a family member, to make healthcare decisions that align with the patient's best interests. Documentation. Thorough documentation of the patient's decision-making capacity, the discussions surrounding their refusal, and the rationale behind the decision is crucial for legal and ethical protection. Relevant guidelines. American Psychiatric Association (NAPAT) Ethics Code Legal Standards for Involuntary Commitment. What ethical considerations should a physician keep in mind when prescribing opioids for chronic pain management, particularly in light of the opioid crisis? Answer: prescribing opioids for chronic pain management involves navigating a complex ethical landscape, especially amid the ongoing opioid crisis. Balancing pain relief and risk. The physician must weigh the ethical obligation to alleviate pain against the potential risks of addiction, misuse, or overdose associated with opioid use. A thorough assessment of the patient's pain and functional status should guide this decision. Informed consent. Patients should be provided with comprehensive information regarding the risks and benefits of opioid therapy. This includes discussing alternative pain management strategies and the potential for dependency. Monitoring and follow-up. Implementing a monitoring plan, including regular follow-up appointments, urine drug screening, and prescription drug monitoring programs, helps mitigate risks and ensure responsible prescribing practices. Multimodal approach. Physicians should consider multimodal pain management approaches combining opioids with non-opioid analgesics, physical therapy, or psychological support to reduce reliance on opioids. Ethical obligations to the community. Physicians have a social responsibility to prevent substance misuse and contribute to community health. This includes understanding the local context of opioid prescribing and being aware of the societal implications of opioid therapy. Interdisciplinary collaboration, collaborating with pain management specialists, mental health professionals, and addiction specialists can provide comprehensive care while addressing the complexities of chronic pain and opioid use. Relevant guidelines. CDC Guidelines for Prescribing Opioids for Chronic Pain. American Pain Society Guidelines. What clinical considerations should a physician take into account when diagnosing and managing asthma in a pediatric patient, and how do these considerations differ from adults? Answer: diagnosing and managing asthma in pediatric patients requires a careful approach that takes into account their unique developmental and physiological characteristics. Age-appropriate assessment. Unlike adults, younger children may not be able to perform standard spirometry tests accurately. Physicians should rely on clinical symptoms, family history, and response to bronchodilators. For preschool-aged children, consider using alternative tools like peak expiratory flow meters when possible. Symptoms presentation. Asthma symptoms in children can mimic those of common respiratory infections, making differential diagnosis crucial. Physicians should be aware of atypical presentations, such as wheezing associated with viral infections. Environmental factors. Evaluate the child's environment for allergens or irritants, e.g., dust mites, mold, tobacco smoke, that can exacerbate asthma symptoms. Tailoring management plans to address these triggers is essential. Medication administration. Children may require education on the use of inhalers or nebulizers. Physicians should demonstrate proper techniques and consider using spacer devices to enhance medication delivery. Asthma action plans. Developing individualized asthma action plans is vital. These plans should include clear instructions for managing symptoms, recognizing exacerbation signs, and when to seek emergency care. Long-term management. Unlike adults, pediatric asthma management often focuses on growth and development impacts. Consider the implications of long-term corticosteroid use and the importance of routine monitoring of lung function and growth. Parental education. Educating parents on the condition management strategies and recognizing signs of worsening asthma is critical. This empowers caregivers to take an active role in their child's asthma management. Relevant guidelines. National Asthma Education and Prevention Program, NEP Guidelines Global Initiative for Asthma, GINA. What are the ethical and practical implications of interprofessional collaboration in patient care, and how can effective communication among healthcare professionals enhance patient outcomes? Answer: interprofessional collaboration is essential in modern healthcare, providing numerous ethical and practical benefits. Ethical considerations. Respect for expertise. Each healthcare professional brings unique skills and perspectives. Ethical collaboration involves valuing each member's input and recognizing the importance of diverse expertise in patient care. Patient-centered care. IPC promotes a patient-centered approach, ensuring that treatment plans reflect the patient's needs, preferences, and values. Shared decision-making, engaging patients in their care decisions and fostering collaboration among healthcare professionals ensures that patient voices are heard and respected. Practical benefits. Enhanced care coordination. IPC leads to more coordinated care, minimizing the risk of errors and redundancy in treatment. This is particularly important for patients with complex health needs who may require input from multiple specialties. Continuity of care. Effective IPC fosters seamless transitions between care settings, ensuring that patients receive consistent and comprehensive treatment throughout their healthcare journey. Effective communication strategies. Regular interdisciplinary meetings. Scheduled team meetings can enhance communication, clarify roles, and facilitate the sharing of information regarding patient progress. Use of technology. Implementing shared electronic health records (AIS) improves access to patient information, enhancing collaboration and reducing the risk of miscommunication. Training and education. Providing ongoing training in team-based care and communication skills for healthcare professionals fosters a collaborative culture, ultimately benefiting patient outcomes.